mis grandes profesores internacionales, el doctor Alistair Thompson. Él viene a Perú ya casi 10 años, ¿no? Desde el 2015. Por lo menos debe haber venido 5 veces a Perú. Bueno, él es profesor y jefe de la sección de cirugía de mama de Baylor College of Medicine. Está en el centro de cáncer que se llama Danville London de Baylor. Y hoy nos va a hablar sobre carcinoma in situ de mama, actualización sobre el manejo. Muchas gracias, doctor Thompson.
Gracias. Thank you so much for the invitation to be here today, Madam President. Thank you. And I would also like to thank the translator who is sitting in that booth, without whom everything I have to say would mean very little. So thank you. As you can see, my Spanish is poquito, and I will have to speak in English. I will try to bring to you some of my knowledge, some of my learning from working in the United Kingdom, when the United Kingdom was part of Europe, and also from the practice of the last 11 years in the United States. So what I would like to try to cover today are these 6 elements to do with DCIS. I am sure you all know about DCIS, but as you can see on the left-hand side of this screen, the normal ductal lobular epithelium proliferates, as you can see in the middle of this screen, and then often there is microcalcification in the center of the duct, which is what, on the right-hand side of the screen, we detect with mammography. Now, DCIS is really a feature of breast screening. I was talking with a colleague from Peru a few moments ago, and without breast screening, it is very rare to find DCIS. The reason in the United Kingdom we started breast screening was to try to reduce the mortality from breast cancer. And that just happened. Perhaps because of better drugs, better radiotherapy, better surgery after the breast screening, but it has happened. But the consequences of breast screening have been to detect many, many, many more patients with DCIS. My first boss was Sir Patrick Forrest. His picture is here. And he introduced breast screening to the United Kingdom. And you can see in that green line how many more diagnoses of DCIS occurred after we started the breast screening program. DCIS is one of several non-invasive breast neoplasias, but it is probably the most important part. Our other problem is that we don't know whether DCIS is going to be no problem for the patient, or whether it is going to transform, develop into invasive breast cancer in the bottom right of this slide. And if it is going to become invasive cancer, we would worry about it. So as you can see on the left-hand side of this slide, we often treat DCIS in the same way that we would treat invasive breast cancer in women. Lumpectomy with or without radiation, or mastectomy, and possibly endocrine therapy. So, DCIS, non-invasive breast neoplasia, sometimes, but not always, becomes invasive breast cancer. So how do we work out what is good DCIS, will never cause trouble, what is not so bad DCIS, maybe cause trouble, or what is ugly DCIS, because it will become invasive breast cancer and potentially kill our patient. So, we know that to distinguish low risk from not so low risk DCIS, we look at the clinical situation. Young women, if there is a mass, if there is very extensive DCIS, we think this may be a risk of becoming invasive disease. And then there are two features looking down the microscope, cheminonecrosis and grade, that we often use to judge, is this high risk or not so high risk of becoming invasive breast cancer? The problem is we rely on our pathologists. Some of my best friends were pathologists before the next two slides. You can see that if you take 39 specialist breast pathologists in the United States, they cannot agree on what they use as a definition of cheminonecrosis. If you take 9 of the most expert breast pathologists in the world, 3 from the US, 3 from the United Kingdom, 3 from the Netherlands, you will see on the top right of this screen that the lowest grade in blue, the intermediate grade in green, and the high grade DCIS, they cannot agree on. And in the lower part of that screen, the low or intermediate good risk DCIS in blue and the high risk DCIS in red, they also are not good at agreeing. So we have a problem as clinicians working with these things. In order to try to understand the problem a little bit more, when breastfeeding got going, we realized DCIS was going to be an epidemic that was practicing in the United Kingdom. We started this project called the Sloan Project. John Sloan was a breast pathologist. He sadly died at a very young age from a cardiac event. But in his honor, in his name, we started this project in 2003. And 21 years later, we are still continuing this prospective cohort study of DCIS and all the other non-invasive breast cancer. One of the components of that is we to evaluate those patients for whom we have a core biopsy that proves there is DCIS. But that patient, for whatever reason, says, I am not going to let you near me to do an operation. You may not do an operation. I'm not going to have an operation. We don't want to forget these patients. And so we have 2 studies we call the Forget Me Not, Do Not Forget patients. It's also named after a very beautiful spring flower we have in the Kingdom called the Emerald. Those 2 studies evaluated 79 women, the top study, or 311 women, the lower study. And we found that for high-grade DCIS, and I know I've been very rude about pathology in high grade, but that was the best we could do. For high-grade DCIS, as the arrow shows, many of those patients went on to develop invasive disease. On the other hand, for low-grade DCIS, you can see that even after 10, 12 years, many did not have any signs of invasive disease. Indolent DCIS, harmless DCIS perhaps. So, trying to understand the behavior of DCIS is difficult. Some progresses, and as you've seen, some does not. And this raised the issue of whether everybody needs an operation or not for DCIS. Now, at this point, the men in the audience should feel a little uncomfortable. You are sitting on your prostate glands. Prostate glands can cause a lot of trouble. But the 2 biggest, best trials of active monitoring, active surveillance of the prostate world, one in Britain, one in North America, have demonstrated that for low-risk prostate cancer, you do not need to have your prostate removed. We're dealing with incontinence, with the lack of ability to do as many men like to, and you do not have to have the androgen deprivation in hot flashes. You can just wait and see. Similarly for thyroid, for small renal cancers, and for cervical neoplasia, we don't always remove those organs. So my friend and my former colleague, Adele Francis, pictured here, was the first person to come up with the idea that we should do a trial of active monitoring versus surgery for low-risk DCIS. And she was the cause of there being 4 trials around the world, as you can see here. Very sadly, Adele died of pancreas cancer 5 years ago, so it's not good to see the outcomes of her. also enthusiastic about the college trial in the United States, which allows women who are 40 years or older who have lupus DCIS randomized to either guideline controlled care, which is surgery, or without radiotherapy, or active monitoring, as you can see in this slide. Now, what I'm very excited to share with you is that the primary outcomes of this COMET trial will be 2 oral plenary sessions at the San Antonio meeting this December. For those of you who are coming to San Antonio, please come along to those sessions. I think they will change practice. I'm biased, clearly. And although I'm not able to share the actual results with you, we are still working on the detailed data. I think this may transform how we approach low-risk DCIS. So maybe not always, maybe not in every patient do we need to do surgery for DCIS. In the meantime, we have 2 big challenges as surgeons: trying to get clear margins and what to do next. The reason we need clear margins is that we want to prevent DCIS or invasive cancer reoccurring in that breast. But in the United States, we do terribly. 1 in 4, 1 in 5 patients in the United States, we do not get clear margins first time around. And if you have to go back and do a second operation, as you know, the complications more likely, pain, misery, time off work increases. And some patients will say, I don't want another breast conservation, I don't want to try lumpectomy again. And they end up with lumpectomy, not second time around, but a mastectomy. Now, the reason margins matter is because we're trying to prevent anything happening in the same spot, in the same breast, in the future. And with the various analyses that we've done for DCIS, we now aim for a 2 millimeter margin if it is pure DCIS. With the dotted lines in pink, you can see the contrast between what we expect of ourselves and our colleagues for DCIS compared with basic disease, where we will accept no cancer cells at the ectomargin. If any of you go to London, and I hope you will, I would plead with you to go to the National Portrait Gallery. It is free. You can store your suitcase there while you go to the National Portrait Gallery. But one of the exhibits is a mask. Strange, it is a mask. A mask that casts a shadow. This is the sort of shadow that we have to work with when we look at mammograms. And if you look at the shadow, just as when we look at the mammograms, it tells you almost nothing about the mask, the DCIS, that casts that shadow. And I don't know whether any of us wear a mask to hide our emotions, but my reason for showing you this is that when we can see the full picture, the full pathology of the DCIS, it may be very different to the mammogram imaging that we've been working with to try to resect the DCIS. So does it matter that the DCIS imaging, the DCIS radiology, in terms of size, is very different from the final pathology, as you can see here? Well, I think it does matter, because on a number of occasions when we try to do the resection, we fail with breast conservation on the left-hand side of the screen, and on other occasions we overestimate the size of the lesion. And so we go for a mastectomy straight away, and we get that wrong as well. And about half of the patients who have a mastectomy for DCIS have a mastectomy because we have guessed the pathology, and we have guessed it wrong from the imaging. So, this is what many of us do. We do the lumpectomy, we take an x-ray of the specimen, we do perhaps paint the margins different colors so we know which margins which, we slice up the specimen, take another x-ray, and we try and get the best possible margin assessment that way. But as you've heard already, that's not perfect. And many people have trying to solve this problem. These are some of the studies that have been done, none of which work well. And the most recent study, aside from the 3D rather than 2D X-rays, aside from the margin probe, the Lumicell study, which has just been published, you can see from those numbers, they were only able to reduce from 16.5% to 12% every operation rate. And I bet there are people sitting in this audience who do better than 12.2% the operation rate for DCIS. I'm sure you're here. So, what we've been doing is using a different technology at Levis and Luke's. Some of you wear glasses, wear spectacles. When you go to an optician, as I do, in the United States, the optician can look at the back of your eye with optical coherence tomography, OCT, and look at the retina at 2 millimeters depth of your retina. What has been done here is to take that same technology and apply it to the lumpectomy placed on the scanner, and to look 2 millimeters into the whole of the periphery of the tissue. We think it works pretty well, because instead of waiting 2 days, it waits 2 days for their pathology report. I wish I did. Or 10 days or 2 weeks, within a very few minutes, you can scan the whole specimen, and as you can see in the bottom right, you can get a picture. We are used to looking at ultrasounds, we are used to looking at mammograms, so we understand these pictures. You can get a picture that will compare very, very nicely to the final pathology. And I have the privilege to be the national lead for this trial, which is multi-sites. It's trying this technology, which, as you can see, looks like an ultrasound machine, and will be relatively cheap to put in place. The last patient was recruited on Monday of last week, and I hope we will be able to present and talk about this study early next year. I don't know what the results are, but I hope it will be positive. So, we struggle with margin assessment, but I think many people are trying to do better and trying to do fewer reoperations. What about in the axilla? A long time ago, it was obvious to us that we do not need to do axillary lymph node dissection for DCIS. Some people still do sentinel lymph node biopsy for high-risk DCIS, grade 3, big palpable masses, young women. But if you use a dye called magtrace, you can actually mark the axillary lymph nodes at the time of your lumpectomy or mastectomy and not have to go into the axilla for the 4 out of 5 patients who only have DCIS in that place. And then for the 1 out of 5 or 2 out of 10 patients who it turns out actually do have invasive disease as well as DCIS in the breast specimen, you can go back at a later date to take the lymph node or lymph nodes out, sentinel lymph nodes. And the first person to do this was a surgeon, Greek surgeon, based in Sweden. He would inject the magtrace, which is iron oxide, coated in dextran, 60 nanometers in size, so it will get taken up by the lymphatics within 20 minutes. I inject it on the table when the patient is asleep. It's painless for the patient. And as you can see, it gives you a dark brown little lymph node, and you can detect that lymph node with a special detector. Great idea, aiming to reduce the number of operations in the axilla and reduce the possibility of lymphedema. His first report of studies showed that this technology, we sometimes call it SPIRE rather than magtrace, outperformed what many of us have used over the years, the blue dye and the technetium. In my own hospital, and I will get into trouble for saying this, the magtrace costs 1/6 of the cost of technetium and blue dye. So it is cheaper and it is better. And to a Scotsman, that is a winner. So at the moment, we're doing a follow-up trial, which we are actively engaged in as the lead site in the United States. As you can see on the left-hand side, every woman with DCIS that we would consider consider doing a sentinel lymph node biopsy on. We will inject the MAC trace at the time of her original surgery, but not touch the ixoma. And then at the top of this screen, for the 4 out of 5 women who do not have invasive disease, we don't have to do anything more. The dye is harmless, it will disappear with time. And we avoid potential lymphedema and the consequences of an axillary wound. However, on the lower part of this slide, you can see for the 1 in 5 patients who actually turn out to have invasive disease that we didn't know about before the surgery. Within 4 weeks, within 30 days, you can take that patient back to the operating room, and we are randomizing patients between using technetium blue dye or using MAC trace first. We use both. We're trying to see which is the better way to find that delayed sentinel node. Now, my prediction from the studies that have already happened is that the MAC trace will win, but we will see. Okay. How can we choose better how to treat our patients? Well, you've already heard me being very rude about my former friends in pathology. Pathology is imperfect, but it has been the best that we've had up to now. And so many have used genomic assays to try and improve our decision making. We're very familiar with these for invasive disease. But in the setting of DCIS, unless you happen to measure estrogen receptor, we do not measure HER2. It's very difficult to know which are the bad characters, the ugly characters amongst the DCIS community. It matters because it may help us select who needs radiotherapy. And radiotherapy, as we all know, reduces the chance of DCIS returning and reduces the chance of DCIS reoccurring as invasive disease. But we have to treat 5 patients for 1 to benefit. And it may be we have to treat 20 patients for 1 to benefit from the invasive disease point of view. So we're over-treating patients if we're not careful. And as a consequence, as you all know, 2 assays are now available, at least in the United States. The Oncotype score, there is some recent literature evaluating that in the Journal of Clinical Oncology just published, and the Prelude decision score. I'm going to talk in 2 slides about the second of those, because I think it may be more helpful to guide radiotherapy. The decision score looks at clinical factors and looks at progesterone receptor, HER2, Ki-67, and other genes on immunohistochemical slides, and you get a score of 0 to 3, low risk, not needing radiation therapy, or greater than 3, high risk. And you can see on the left-hand side, if you have the low risk score, no point in getting radiotherapy. Whereas if you have the elevated risk score of 3 or more, you do benefit from radiotherapy. So, people are critical of these assays and that they're using old specimens. They need you to send samples, they need you to send sections to California, where both companies are based. And for me in the United States, yes, the insurance company will pay, but it is $4,000 to get one of these tests done. That is a lot of money for this mean Scotsman, that's for sure. So in future, I think there will be other assays coming along. With the dreaded COVID pandemic, many of our labs, even in small hospitals, have the ability to look at RNA in human samples. It's how they were testing for COVID on many occasions. And so being able to look at the RNA in DCIS might tell you, as this shows, those who have no chance of anything bad happening, the red line with the pink arrow, and those with the blue line who are most likely for invasive disease to happen in the short term. We'll see. So what I've tried to do over the last few minutes is think, is there anything you and I should be doing differently on Monday morning? I think there maybe are 2 things we should do differently. The first is to recognize that even if we do our best it is an imperfect situation that we have to discuss with our patient how difficult it is to manage DCIS. And then secondly, to keep our eyes open for the results that are coming along, for example, for the COMET trial, that may change our practice. With that, I thank you all for your attention, and thank you for making me so welcome here in Lima, Peru, and it's been a great pleasure talking with many of you. Thank you so much.
Por favor, si alguien del auditorio tuviera preguntas para el doctor Thompson, por favor, levantar la mano. Yes, Dr. Cowell, please.
Alistair, fantastic talk. Really learned a lot and really framed it very well. I'm curious about the decision score, because I really have no experience with that. The Oncotype score in DCIS I always felt was not terribly helpful. There was a lot of middle ground that you just didn't know what to do. The decision score, do you feel like it differentiates more, and do you think that's because of the clinical input, or what are your thoughts on how it's different?
That's a great point. So, first of all, Oncotype for invasive disease, and I know you have a stand here, I know they're sponsoring. It is the most widely used test in the United States, with good reason. It's useful. The Oncotype for DCIS is not widely used in the United States. Maybe that tells you something. For the Prelude test, there is still a need for a randomized trial which will test the test fully, prospectively. Many people, such as our organization, routinely will ask insurance companies to pay for the test, and they almost always do. And we use it in discussion with the patient. So it helps educate the patient, and some patients, clinicians, change their practice. Maybe 1 out of 3 times we change what we do as a consequence. At the moment, I don't think it's a perfect test because it hasn't been perfectly tested. But I think there are 2 randomized trials about to start, one with an organization called NRG in the United States, one with an organization called SWOG in the United States. And I think that will define, probably in 10 years' time, just how good the test is. Thanks for your question.
Si alguien más tuviera alguna pregunta para el doctor Thompson, la doctora Gale.
Doctor Thompson, ¿usted podría brindarnos alguna opinión del manejo del carcinoma in situ en pacientes mayores de 70 años? Y obviamente tenemos una cantidad creciente de pacientes jóvenes con carcinoma in situ. ¿Usted ha identificado algún factor de riesgo? ¿Usted cree que el iniciar la mamografía de pronto a una más corta edad podría ser como una herramienta importante?
So the question of age for invasive cancer and for DCIS is a very good one. And for older women with DCIS, particularly if it is low grade, some will say, I do not want any surgery, and I respect that. It is different for a 40-year-old woman, particularly with a larger area of DCIS, which in her lifetime may well progress. But for a 70 or 80-year-old woman who has 10 or 20 or 30 years to live, it is not quite the same. And for many, I will monitor those patients with annual mammograms by agreement with the patient. Many do not want to take tamoxifen. Many do not want to take aromatase inhibitors because of the side effects. And usually over a period of 4 or 5 years, either nothing happens, in which case we continue annual monitoring, or the DCIS on imaging starts to change, become more widespread, in which case for the 75-year-old, I can say, this is changing. Maybe we should act. I hope that answers your question. Yeah. Gracias.
Sí, la doctora Cruz tiene una pregunta.
Doctor, agradecida por su presentación, muy interesante. Mi pregunta se va respecto al riesgo de recurrencia. Los pacientes, es importante identificar qué pacientes con CA bucal in situ tienen alto riesgo de recurrencia y quienes no tienen tanto riesgo de recurrencia para nosotros enfocarnos y tomar las decisiones adecuadas. Ahora, el Memorial International Catering ha publicado hace unos años un homograma para identificar qué pacientes que han sido sometidos a cirugía de conservación de la mama tienen alto riesgo de recurrencia y quienes tienen un bajo riesgo de recurrencia, y de acuerdo a eso poder guiar decisiones. Ahora, hay otro estudio además que ha salido comparando el nomograma del Memorial International Catering con el Oncotype, han evaluado que el nomograma del Memorial International Catering no es inferior al Oncotype, incluso es mucho más barato, está en línea y es gratuito. Me gustaría saber su opinión al respecto. Gracias.
Thank you so much. Cheap things online can be very good. And if it helps you to make your decision and helps your patient have the right treatment, I would encourage you to use the nomogram. There are some slight problems with the nomograms that are online, that often they are built on specific patient groups, particularly the memorial nomogram may or may not be relevant to patients in Houston or Lima or Arequipa. I don't know. And if it helps guide you, that's fine. But it's probably an imperfect tool, as all the other tools are, to allow you to guide your patient. Yeah? So please use the nomogram if you find it helpful. I find it helpful sometimes for some patients, but most of the time I rely on the more molecular tools if I have them available. Thank you.
I have one final question for you. So here in Peru, we don't have screening with mammograms, but you do. Do you still receive DCIS in presentation of masses? Because what we see in Peru is almost always it is a mass, unless it has microdots in the mammogram.
You make a very good point that the practice in different countries and different parts of different countries can be widely variable. If you are not seeing screen-detected DCIS, if you are seeing palpable, widespread, big masses for DCIS, then I think that is a different beast, a different disease to what we have been detected through breast screening. And treating it more like invasive disease, as we both do, I think is more appropriate than this screen-detected DCIS that's a much lower problem.
Thank you very much.
Thank you.
Big aplauso, por favor. Los aplausos.